Case 1. Mrs. M is a 52-year-old female. She comes in today reporting that her depression has been worsening over the past 3 months. She has a 10-year history of depression and was taking Prozac, but switched to Cymbalta 1 year ago due to chronic back pain. Her back pain has increased. She also has complaints of increased fatigue and has not been going places or doing anything. She finds doing the dishes difficult because of the pain and fatigue. She reports panic attacks, which are new to her. They last approximately 5 to 15 minutes. During them, she experiences shortness of breath, palpitations, shakiness, and sweat. Afterwards, she is exhausted. She reports urinating small, frequent amounts and feeling urgency. She also reports weight loss, decreased appetite, although she feels she still eats the same amount of food. At her last appointment, she was 129 pounds. Today, she is 119 pounds. Her past medical history includes depression, gestational diabetes. Her sugars have been followed since then in the office, and they've always been normal. A history of intermittent indigestion, a cholecystectomy in 2000, and an appendectomy in 1992. Medications: she takes Cymbalta, Tylenol and Advil, PRN for back pain, a muscle relaxer PRN for back pain, Zantac over the counter 2 to 3 times per week, Ultram PRN. She had her last script 3 months ago for 30 pills. Her social history: Mrs. M is a widow. Her husband died 3 years ago. She lives alone in her home. She has 2 adult daughters that live close by. She was a stay-at-home mom who had not worked since her youngest daughter was born. She used to babysit her granddaughter in the morning, but says she is unable to do so anymore because she is too nervous. She does not exercise regularly. She does not smoke. She denies the use of street drugs. She drinks 3 cups of coffee and 1 Mountain Dew per day. Review of symptoms: she admits to fatigue, denies diarrhea or constipation, admits to intermittent indigestion and decreased appetite, denies nausea and vomiting, denies chest pain except during panic attacks, admits occasional headaches, denies dizziness, admits to shortness of breath, palpitations, shakiness, and sweat during her panic attacks. Physical exam: her general appearance: she is anxious and speaks rapidly. Her height is 5 feet 3 inches, weight 119 pounds, temperature 99.2 degrees Fahrenheit, pulse 94, respiration 22, blood pressure 128/82. Eyes, nose, throat are normal. She has a possible slight fullness in her neck. 0 nodules are palpated. Her chest, her lungs are clear to auscultation. Her heart rate is rapid, regular, without murmur. Her abdomen is soft, non-tender, positive bowel sounds throughout. She has no peripheral edema in her extremities. Fetal pulses are 2+ bilaterally. She is positive for a fine tremor. Differential diagnoses for Mrs. M include hyperthyroidism, serotonin syndrome, and diabetes mellitus. Hyperthyroidism is the most likely. It was chosen because she exhibits the signs and symptoms of anxiety, weight loss, rapid heart rate, tremor, irritability, panic attacks, and fullness in the neck, which are all signs and symptoms of hyperthyroidism. Serotonin syndrome is next. It is likely because Cymbalta and Ultram both increase the serotonin levels, and there is a significant risk for reaction that should be monitored. The patient exhibits some of the signs and symptoms of serotonin syndrome, such as agitation and tremor. And 3, diabetes mellitus. She does have a history of gestational diabetes. She is exhibiting some polyuria, weight loss despite normal food intake, and fatigue. Possible diagnostic testing for Mrs. M. Today I would have lab work drawn. Lab tests would include TSH, total free T4, total free T3, also a random non-fasting plasma glucose concentration. Since she's not been fasting today, I would do that to check her blood sugar. If it's over 200, it is possible that she is diabetic. Would also have a hemoglobin A1C drawn to see her glycemic control over the last few months. I'd also do a CBC, a Chem panel, vitamin B12 level to rule out other causes of fatigue and for overall general health. A 24-hour radioactive iodine uptake study could be ordered, but I would order the other thyroid labs first and see how the results turned out before I would order that. So I would actually put that off until later. I would wait for all the results of these tests before initiating a treatment plan. Case 2, Mr. D is a 59-year-old incarcerated male here for a return visit, complaining of dysphagia. He presented 3 weeks ago, complaining his allergies were causing a lump of phlegm in his throat that he could not shake. He was given Flonase and told to return in 3 weeks. He now complains of dysphagia, difficulty eating meat. He has to chew bites at length, and sometimes they still get stuck. He is able to swallow fluids. He reports having lost weight. 3 weeks ago he weighed 168 pounds. Today he weighs 169 pounds. He reports fatigue. He also reports GERD that flares up 2 to 3 times per week. He takes over-the-counter Zantac for that. He used to take Prilosec, but it is no longer on the prison formulary, and he cannot afford it. He had an EGD approximately 10 years ago for recurrent GERD. He does not recall any abnormalities from that EGD. His past medical history includes significant alcohol intake over many years, history of significant GERD, type 2 diabetes that is under good control with metformin, hypertension that is controlled with lisinopril, a history of BPH, a history of multiple gunshot wounds to the abdomen at age 29, an appendectomy at age 14. Medications include metformin, lisinopril, over-the-counter Zantac, Tytran, and that is all. Social history, he stays in prison, significant alcohol use. He's a 45 pack per year smoker. Review of symptoms, he admits to fatigue and weight loss. He denies nausea, vomiting, diarrhea, or constipation. Physical exam, his general appearance. He is alert and in no apparent distress. Height 5'10", weight 169 pounds, temperature 97.8, pulse 68, respirations 20, blood pressure 116/78. His head, ears, nose, and throat are unremarkable. His chest, his lungs are clear to auscultation. His heart rate is regular rate and rhythm, without murmur, rubs, or gallops. His abdomen is soft and non-distended. Bowel sounds are positive ×4. He has no peripheral edema. Pulses are 2+ throughout. 2 months ago, his hemoglobin A1C was 6.4%. 2 months ago, he also had a normal chemistry panel, normal liver and kidney function test. Differential diagnoses for Mr. D include Barrett's esophagus, esophageal tumors, and hiatal hernia. Barrett's esophagus is what I chose as the most likely because it is more common in older men over the age of 50, also in those that have long-standing heartburn. He exhibits some of the signs and symptoms of Barrett's esophagus, including chronic heartburn, dysphagia with solid food. His physical exam findings with Barrett's esophagus can be completely normal, and his was. Second, I have esophageal tumors. He has multiple risk factors for that, including male over the age of 50, excess alcohol consumption, tobacco use, chronic GERD, and he exhibits the symptoms of dysphagia and weight loss that go with esophageal tumors. 3, hiatal hernia is possible, but the least likely of the 3. He does exhibit the signs and symptoms of heartburn, dysphagia, and occasional chest pain. Diagnostic testing that I would order, I would actually order an EGD with biopsy. This would visualize the esophagus, upper GI tract, and everything for all 3 of these differential diagnoses. I would also do a CBC, Chem panel, and liver enzymes again. The CBC would be ordered to make sure that he is not losing any blood anywhere in his esophagus. The Chem panel I would do to check for electrolyte imbalances, and the liver enzymes just to check with his history of alcohol use. I would await the results of these tests before considering a further treatment plan. Case 3, Mr. G is a 36-year-old Hispanic male. He complains of persistent cough for the past 3 months. He reports his cough is dry most of the time, occasionally productive with clear sputum. His cough has not gotten any better or any worse. He also has a stuffy nose and thought that with the stuffy nose and the cough it may be from his allergies. He has had allergies for years, but never had a cough with it quite like this previously. He also reports night sweats, but he has not checked his temperature. He has been fatigued, but thought it was from starting a new job. 3 months ago, he began a new job in a hot warehouse and has been working a lot of overtime. He denies any recent exposure to contagious illnesses, including tuberculosis. His past medical history includes a history of allergies for many years, asthma as a child, but states that he grew out of it, hypertension that is controlled with lisinopril, 20 milligrams per day, and he takes no other medications. He has a family history of hypertension, asthma. His maternal grandmother has type 2 diabetes, and his mother has migraines. Social history: he lives with his girlfriend and her 2 children. They have 1 child together. He is from Texas, but was born and raised in Mexico. He is a former 1-pack per day smoker since age 16 and quit 6 months ago. Review of symptoms: he denies nausea, vomiting, constipation, and diarrhea, and heartburn. He admits to shortness of breath with exertion. He denies wheezing, and he denies chest pain. Physical exam: height 5 feet 11 inches, weight 180 pounds, temperature 99.2, pulse 72, respirations 18, blood pressure 134/84. His nasal turbinates are gray and bulgy. His pharynx is injected with clear postnasal drainage. No sinus tenderness or lymphadenopathy. His lungs are clear to auscultation. Heart rate regular, without murmur, rub, or gallop. His abdomen is soft and non-tender. He has no peripheral edema. Differential diagnoses would include tuberculosis, allergic rhinitis, drug-induced cough, and asthma. I believe tuberculosis would be the most likely diagnosis. He has multiple risk factors, including race, age, and gender. Also the fact that he is an immigrant from Mexico. He is also exhibiting multiple signs and symptoms of tuberculosis, including fever, night sweats, cough, scant non-purulent sputum. Second, I would consider allergic rhinitis because the physical exam shows gray and bulgy turbinates, which are a sign of that. Also, his pharynx is injected with clear postnasal drainage, which is also a sign of allergic rhinitis. He also has a history of allergies and a stuffy nose, and is working in a new environment around possible new triggers. Third, I have drug-induced cough. The patient is on an ACE inhibitor, lisinopril, and cough is a common known side effect of the drug. Fourth, I have asthma. I have that as the least likely, just because I don't think it's as likely as the previous 3. I know he does have a history of childhood asthma and a cough with shortness of breath on exertion, but he does not have any signs of wheezing, no use of accessory muscles while breathing, and no tachycardia. Diagnostic testing: I would order a sputum for AFB stains and culture. This is needed for a positive diagnosis of TB. He would need a positive AFB smear. It's essential for the diagnosis and determination of treatment options. I would also order a chest x-ray. It is recommended in the chronic cough algorithm, also helpful in determining if the patient does have TB, if it is primary or reactivated TB. I considered ordering a tuberculin skin test possibly, but I think that the previous 2 tests are more important, and just to keep costs down, I would almost skip the TB skin test and just do the sputum, stain and culture, and chest x-ray. I would also order spirometry to test for the diagnosis of possible asthma, just because he does have a previous history of childhood asthma. And then we would go from there.